Hello, everybody. My name is Vittoria Vergani, and I'm an academic foundation doctor at Guy's St Thomas's Hospital in London. In this presentation, I will talk to you about shared decision-making, what it is, and why it is important. I will also share with you some tips on how you can practice shared decision-making with your patients already at the junior level. My first F1 job was in POPS, which for those of you who are not familiar with the acronym means Perioperative Medicine for Older People Undergoing Surgery. It is a geriatrician-led service to optimize elderly and frail patients and consider appropriate therapeutic options prior to surgery, and to medically manage the same patients on the ward after the surgery. Shared decision-making was an integral part of my job in POPS, and at first, I found it almost daunting. But with teaching, research, and some work on the subject, I developed the tips that I will share with you today. To start, watch this video that displays a physician-patient interaction. These and the following videos are currently shared by Lawrence Mudford, a patient representative of CPOC, the Center for Perioperative Care, which is a cross-specialty center dedicated to the promotion, advancement, and development of perioperative care for the benefit of both patients and the healthcare community.
Well, Mr. and Mrs. Williams, nice to see you again. I've now had the X-ray report that shows that your right hip will require an operation to stop the pain that you're experiencing and allow you to live a normal life again. The waiting list is around 18 weeks at present, and I will arrange for you to be put on it. Any questions?
Okay, so at first, I think this conversation seems a perfectly normal interaction, which is led by a polite and very efficient doctor. However, if you think more deeply, you may have noticed that this is a completely unilateral conversation with a unilateral decision where the patient has little to no role. This is known as paternalistic approach, where the doctor, because of their profession and knowledge, considers what is best for the patient, and we could say decides for them. In the recent years, the approach to medical decisions has shifted from paternalism to shared decision-making. The value of shared decision-making is increasingly recognized, and its implementation is supported by international initiatives, such as Choosing Wisely, and is advocated by NICE guidelines. So what is it? Shared decision-making is defined as a collaborative process whereby healthcare professionals and patients work in partnership to reach a treatment decision based on a clinician's expert knowledge as well as the patient's values. The clinician's role in shared decision-making is to inform the patient of the diagnosis and predicted risks and benefits of the available treatment options, using experience and scientific evidence to provide this information. The patient's role lies in articulating the impact of the condition and proposed treatments on their life, and also to articulate their outcome preferences. The clinician and patient are then able to come to a shared decision on the most appropriate intervention and ongoing care. Shared decision-making should be at the base of any medical interaction. However, it is particularly important in the context of elderly care, where patients are often comorbid and may suffer from frailty syndrome, which is characterized by a lesser physiological reserve to overcome any physical insult, and where this physical insult is not unlikely to cause further cognitive and functional deterioration, or both. This is something you may have experienced in your medical career so far. When we speak about new baseline, when we consider if a patient can be safely discharged from hospital, for example, this may refer to the degree of cognitive impairment, as well as the degree to which patient depends on others for their activities of daily living. It is not uncommon that hospitalized elderly patients will need an increasing package of care or beginning of package of care on discharge. Along this line, you can see how decisions about surgery are especially tricky in the elderly population, and how patients' perspective is of fundamental importance in making the best decision tailored to their needs. So why did we shift from a paternalistic approach to shared decision-making? I will now show some data that highlights the positive impact of shared decision-making. First, a study conducted by Harvard Medical School. It assessed patients' understanding of procedure, indication, risks, and benefits of the procedure when they presented for appointments at the Perioperative Assessment Center of an academic tertiary center. Patients' understanding was tested by means of a survey, and 1,034 patients were enrolled in the study. They found that 13% of patients exhibited deficits in their informed consent process. These are critical deficits that include patients being unaware of procedure, why they are undergoing it, and of the associated risks and benefits. 33% exhibited other types of deficits, including not having addressed patients' values, preferences, and goals. These basically translates in a third of interactions with patients not offering effective shared decision-making. And please remember that these are numbers coming from a world-renowned academic center. And we would probably imagine that these deficits may be greater in less resourceful environments. To conclude, this study suggests that in the absence of shared decision-making, patients are at higher risk of consenting to medical care that they do not understand and therefore may not necessarily want. Interestingly, in this study, it was also highlighted that there was a higher risk for deficits among non-English speakers and patients with lower level of education. The second set of data comes from Dr. Malak, a POPs consultant in East Kent Hospital University NHS Foundation Trust, and she was so kind to share this data with us. The data reflects the outcome of POPs clinic for vascular patients who mainly suffered from abdominal aortic aneurysm, but also had other peripheral vascular diseases. Patients are referred to this clinic if they are elderly or frail, with the aim of medical optimization and further consideration of treatment options. What they found was that 40% of all patients who had a surgical choice and could choose whether to consider surgery or not, therefore were fit enough for surgery, and they are the patients in the bottom two bars of the chart, 40% chose not to have surgery. In the second graph, you can appreciate how frailty is a very important variable that affects the outcome of the decision. You could speculate that frailty affects both sides of shared decision-making, the physician and the patient. On one hand, physicians are aware that scientific evidence suggests that invasive procedures can cause more post-operative functional and cognitive decline in the frail population. And on the other hand, frail patients faced with the risk of deterioration of their quality of life may be more likely to choose quality over quantity of life. This highlights the importance of shared decision-making in the elderly population. This slide summarizes the key advantages of shared decision-making and why it was so important that we shifted from a paternalistic approach to this new approach. Shared decision-making allows to tailor care to the needs of the individual. And as we just said, this is particularly important in the frail and elderly population. Informed patients feel empowered to make active decisions, often resulting in higher satisfaction with the care and lower rates of litigation. On the other hand, also physicians feel reassured that they are acting in the patient's best interest. In an era where medicine has produced so many options, it is difficult to know what the best one is, and often, scientifically speaking, there isn't a best one. Therefore, knowing what the patient wants empowers us to navigate these options and tailor treatment to the patient. Also, in general, both patients and clinicians tend to overestimate the benefits of treatments and underestimate their harms, resulting in inefficient allocation of resources. This is so important today in the NHS, where fair allocation of resources is at the heart of the system, but unfortunately, it's often challenging. And as a last point, we have seen evidence of specific groups being most at risk of having insufficient understanding of their medical care. These disadvantaged groups would be protected in an environment where shared decision-making is promoted. So, but how do I do shared decision-making? I will now show you another video from Lawrence that revisits the previous physician-to-patient interaction.
Well, Mr. and Mrs. Williams, nice to see you again. I've now had the X-ray report that shows that the pain and poor mobility that you're experiencing does come from your right hip. There are a number of options that you could choose. I would like to chat through these to help you understand what you feel would be the best option at this time. Then I have some leaflets that you can both take away to hopefully help come to a conclusion and a decision. But before we look at those options, I'd like to hear a little bit about you so that I can understand what matters to you, how this condition is affecting you, and what outcomes you would see and expect following any treatments that you may choose.
Okay, so you will have noticed how the focus of the conversation has shifted towards the patient and the best decision for the patient. The conversation is no longer unilateral and shows a desire to create partnership between the physician and the patient. The doctor in this scenario uses some keywords and phrases that you might have noticed, like options, help you decide, about you, what matters to you, and expectations. On this note, shared decision making is an excellent place where to be open with patients and start managing their expectations. The last part of this presentation will focus on some tips you can use to practice shared decision making at any level, including that of a junior doctor. First, the same way you use an A to E structured approach to assess unwell patients, a structured approach will help you navigate shared decision making with comfort. The A to E of shared decision making is called BRAN. B stands for benefits, and as in, what are the benefits of the proposed treatment? R stands for risks. A is used to explore the alternatives, and N helps you consider what would happen if the patient decided not to do anything. So N stands for nothing. The second tip is, when you explore the benefits, find out the specific and personal positive impact that the general benefits will have on the patient's life. During the assessment, find out what is important to the patient. Ask them. For example, a hip replacement would be particularly valuable to someone who can have and still desires an active life. In this case, the operation would have the benefit of helping to reach the patient's goals. Then, when you consider the risks with the patient, do not worry if you're not familiar with the procedure and the specific risks. The patient will be informed about these during the consent process, and shared decision making is not the consent process. Again, the most important aspect is to make this a tailored approach where you address the patient's concerns and fears and you manage their expectations. One feature that is often overlooked is post-operative pain, and this is an excellent place to discuss it with the patient. Patients should be aware that pain is expected after surgery. At the same time, the aim is to manage it as well as we can, rather than abolish it completely. Delirium is another important aspect. Delirium is often seen as affecting the elderly only. However, it can happen at any age, and all patients should be counseled about it. More tailored to the elderly and frail is a discussion about possible decline of the functional status. Remember that many of these complications are not truly quantifiable. This can be tricky because patients often would like to have certain information. However, they also appreciate and feel reassured by open conversations. Talking about uncertainties is perfectly acceptable. In fact, it is necessary to build a good relationship with the patient and to make good decisions. Another tip is that you might need to speak to your consultants and other specialists to close the loop and achieve high quality shared decision making. This is a positive result. You gave the patient the opportunity to ask questions, and you will find out the answers before the surgery. So always encourage them to ask questions, even if you might not know the answers. Your senior colleagues can always help you, and often multidisciplinary teams become involved in complex cases. Remember that also your consultants often need help. My last tip is to summarize the discussion at the end of the conversation. This will allow you to check that you have discussed everything you wanted to, then summarize the outcome of the discussion. If a decision has been made, summarize it. If not, summarize the next steps before a decision will be made. Okay, now to conclude, I will show you the continuation of the last video we watched, which is a great example by Lawrence of how to end the shared decision-making conversation.
Well, Mrs. Williams, if I could summarise, Although you feel that the hip operation that we discussed is the best option for you, you've also chatted with me about your current circumstances. You mentioned that you were booked to travel to Australia to see your daughter and your grandchildren in 2 months' time, and that this was likely to be the last big international trip that you and your husband expect to make. So that is a big priority for you. So having looked at the benefits, the risks, and the alternatives, as well as considering not doing anything, you've chosen to defer the operation until the autumn so that you can visit your family. We will arrange a short-term steroid injection along with painkillers to help you have that important holiday, and then look to book you in when you return to the United Kingdom. I'm happy to support your decision, having spent time understanding the options and the choices open to you, and recognising that you've been able to make this decision in a way that's best for you at this moment.
Okay, this is the end of the presentation. I hope that you found it interesting and the tips will help you practicing shared decision making with your patients. Thank you all for listening. And I would also like to thank Lawrence Mutford from CPOC, the Center of Perioperative Care, for kindly providing such useful videos. And thank you also to Dr. Catherine Meliak for sharing the outcome of her hard work at East Kent Hospitals University's NHS Foundation Trust.